I'm Catherine Cunningham with the Sierra Nevada Forums. Along with our partners, AAUW Capital Branch and the League of Women Voters of Northern Nevada, we are proud to welcome you to tonight's forum. These forums would not be possible without the generous support of our co-sponsors, the Nevada Appeal and KUNR Public Radio. Sierra Nevada Forums is celebrating its 11th season of offering free, informative, thank you. Our mission is to provide citizens with factual, verifiable information to assist them in making well-informed decisions on issues of importance to our community. Our organization is run solely by volunteers. If you enjoy the content we provide, please consider making a donation. And by the way, we are always looking for topics for future forums. So if you have suggestions, write them on an index card or tell one of our volunteers, but we would love your input on that. Since the hectic holiday season is pretty much here, we will not be hosting a forum in December. But we have a very special program on January 13th featuring Professor David File-Cipher of UNR's Computer Science and Engineering Department, who will be demonstrating the many uses of robotics. And many of you may remember him from the AI presentation last spring, but he promises to bring some of his very cool robots, so it should be a great program. And if you, with all of our programming, please check our website, sierranevadaforums.com, for additional information. We have spectacular high school students stationed in the aisles to take written audience questions throughout the program. If you have a question, just wave to them. They'll hand you an index card, which will be presented to our volunteers at the front table. They're just going to be reviewing the questions just to avoid duplication. As many of you know, cancer is indiscriminate in who it targets. It crosses over all age groups and demographics. Its impact on patients and families can be overwhelming. Fortunately, we have an excellent panel of experts who are graciously lending their time to offer clarity and hope as they walk us through the various treatments and supportive care programs that are currently available. Our moderator this evening is Dr. Tim McFarren. Dr. McFarren has been a respected leader in the Carson City medical community for decades. Dr. McFarren is a board-certified OBGYN with extensive experience in clinical practice. In addition, he is a tireless advocate for excellence in patients' care on both the state and national level. Please join me in welcoming Dr. McFarren.
Thanks, Catherine. I hope I can live up to that. Gee, many. Well, again, welcome to Sierra Nevada Forum, and also it is Veterans Day, and I would like to thank all the veterans who are in the audience and who are not here for their service and sacrifice, and keep you guys safe. So, according to the American Cancer Society, almost 2 million Americans, a little bit more than 2 million Americans will be diagnosed with cancer this year, and about 700,000 will die. Everyone in this room has been affected by cancer, either personally or a family member or a close friend. Just hearing the word cancer, what emotion does it bring up? Sadness, fear, anxiety. Yet there is hope and promise, and in the fight against cancer, early detection, diagnosis, treatment is what tonight's panel will be discussing as far as today's and tomorrow's successes. So joining us tonight are Dr. Ragneel Bijjula, Carson Tahoe Health, a medical oncologist. Lindsey Foxen, an certified oncology nurse who helps patients navigate the complexities of cancer healthcare. I consider her probably the most important member of the cancer care team. And Dr. Schwartzberg, Renown Health, also a medical oncologist. So let's get started. Dr. Bijjula, would you like to lead off tonight's discussion?
Yes. All right, so this is a big topic, so I'm going to try my very best to make it as simple as possible. I'll try to make it so that you don't need a PhD in biology to understand any of this. And so I'll start off with first at least framing the different concepts which we have to understand to see how things have changed from before. One of the common questions, I want to start off with by saying this, one of the questions I get from one of my patients is, we were able to put a man on the moon, how is it that we were unable to cure cancer? And the answer to that question is, it's complicated. The reason being, putting a person on the moon was a complex engineering problem. Solving cancer is a complex biological problem. We always used to think that cancer as a diagnosis was one disease, when in fact it encompasses a lot of diseases within it, even though it just is one word. So we always thought the cure, the treatment was just with one treatment, when in fact it's a very overly simplistic way of looking at it. Let me look at the clicker, which I forgot. All right, so this is the more traditional approach, where previously it was one size fits all, where we used to use chemotherapy, which is like one of the analogy which you'll probably keep hearing the rest of the talk is analogy which I compare the cytotoxic chemotherapy is like a sledgehammer, where you pretty much treat not just the cancer, but along with the cancer, some of the collateral cells which get damaged, and that could be your hair or cell linings which are fast growing. So, and that's been the primary modality of treatment. It was more based on location. You see there on the left, traditional approach was organ of origin, lung, breast, colon. So you have the disease in particular organs, so you go after it specifically, and that was the conventional way of looking at it. Now, when you come onto the right side, where it's more precision medicine today, what does this mean? It means that there are certain cells which seem to be growing, which seem to be growing rogue, and we try to pick up on certain molecular findings, genetic, cellular reasons as to why they're going rogue, as opposed to just looking directly beneath the microscope, which will be in the left side with the cell appearance under the microscope and just staging. It doesn't take away the fact that we still use that. We still use the staging, we still use the microscope, but I'm just saying that in terms of deriving where the cancer is coming from and what the environment which it needs in terms of mutations, that's being added on top of our conventional way of thinking. So this is a more chronological slide of how things have changed. So you look at this at the early in the top, where the cytotoxic era, the 1970s to 1990s, was all chemotherapy targeting the dividing cells. We moved again more to the 2000s, where it's more targeted treatments with HER2, anti-HER2 agents, such as for breast cancer. Then it was the genome revolution in 2010s, where it was the discovery of the EGFR, ALK, and ROS. Now, in much more in the late 2010s, addition of immunotherapy for treatment, checkpoint inhibitors. Now we're getting into the next phase, 2020s, is going to be the AI-assisted care, where there's real-time monitoring of the cancer itself as we are treating it, which I'll get to in a later slide in terms of details. So, I mean, this is another way of looking at it in terms of organ-centric era, where previously in the pre-2000s, where treatment decisions were primarily based on tumor origin, which I just said. It was more anatomy rather than the biology. It was more the address rather than the blueprint of the cancer. Blueprint meaning as to, again, the why are there some of these cells which are going rogue in terms of particular mutations. So one of the examples which I can give is rectal cancer. So back in pre-2000s, so there was cancer in the rectum. What do we do about it? We used to surgically remove it. And that was the way to go about it in pre-2000s. Then they realized in early 2000s, okay, so why are some of these patients where rectal cancer is being removed, why are we seeing reoccurrences? Then we realized the role of neoadjuvant chemotherapy, where we try to give chemotherapy before the surgery. just to reduce the cells, some of the what we call as micrometastatic disease, or the floating cancer cells in the body. That seems to improve the overall survival. That seems to improve the rectal, like this preservation of the rectal sphincter. So that seems to make a difference in the early 2000s, and that was when, in the 2000 to 2010s, that was the way we were doing it. Then the targeted therapies era. So we did the neoadjuvant chemotherapy, we did the surgery, but there were still some patients where we were unable to see adequate response. Then we later found out there are some mutations, such as BRAF mutation, or even MSI high tumors, which are the signatures, which I'll talk to you in the later slides. That particular signature in certain cancers, they don't seem to respond to chemotherapy much. So we identified that in the targeted therapies era. Now in the later era, in the multi-omics, and the integration of the genomic, transcriptomic, and the proteomic data, what does this mean? It means that we're really looking at one of the ways to look at it genomic is the DNA itself. The transcriptomic is the mRNA, which is the synthesis of the DNA, because there are certain genes which are silent, there are certain genes which are on. So we're trying to figure that out along with the proteomic data, where we measure directly the protein, which is synthesized directly from the mRNA. So we have a little bit more integrated, more comprehensive approach to identifying the cancer cells. And I'll give you examples so that it all makes sense in the next few slides. So how do we test this? We have a tissue. So we do need a tissue biopsy, just with a regular, putting a needle into the affected organ where we think the cancer is. And that would and then we extract that tissue cells into the DNA. That is run with what we call as gene sequencing now, which has become very prevalent in pretty much all cancers, where it's like a multi-code bar scanner, where it looks at all your DNA and RNA to pick up on any particular mutations which are directly relevant to the diagnosis of this particular cancer. Then that's when the pathologist puts out the report. So targeted therapy. So I know this is one of those frequently used words, and this is something which a lot of patients ask me specifically what this is. And I think the best way to explain this would be to give two analogies. One would be to give like a lock and key. The way to think about, remember before I said it's not the anatomy as much as the biology, where there are certain cells which are going rogue with certain mutations. So targeted therapies is analogy which I keep giving is like a lock which has a specific key, and this particular lock keeps sending out the growth signals for the cancer cells to keep growing. Targeted therapy is giving that particular making a key and jamming it into the lock so that it stops sending out that growth signals, so that the cancer cells stop growing. Or the other way to think about this is like a sniper rifle, where instead of chemotherapy being like a sledgehammer inhibiting all the cells, not just the cancer cells, the sniper rifle is more geared towards blocking a certain particular protein by itself. Now we have a lot more mutations when compared to before. So back in 2015, we only had like an EGFR and ALK and ROS. Since then, this is for lung cancer. We have MET, RET, and we have BRAF in colon, KRAS G12C just 3-4 years ago, NTRK 1 or 2 years ago, PDL1 around 10 years ago, HER2, this has been there for some time, more than 15 years. But things have rapidly evolving in identifying all these particular mutations. And one of the other questions, I'm kind of framing up the platform before we actually get into the actual cases themselves. Now, the other frequently asked question is about what is immunotherapy. And the immunotherapy, the analogy which I try to give is immunotherapy is more like the analogy about like a personal trainer. The cancer cells in your body, they're really masquerading as cells of your own. They have that shield on, that cloak on, saying there's nothing to see here, keep moving on to the immune system. And the immunotherapy removes that cloak so that the cancer cells can recognize them, more specifically the T cells, so that they can attack them and kill them. And that's why I mean, like, cancer disguises itself with that PD-L1 saying, don't attack me. Then we have the drugs like pembrolizumab. There are many other ones which primarily work on that PD-1 and the PD-L1 interaction, then leading to the immune system recognizing it. Now, this is another topic which I'm sure Dr. Schwartzberg is going to get much in detail, but this is like the liquid biopsy, the monitoring of the treatment. This is one interesting, at least I'd like to share the origins of this which I find extremely interesting. It was back in late 1990s when in Chinese University of Hong Kong, Dennis Lo, a physician, he had this hypothesis, well, if there's like a baby growing in a pregnant woman, which is like a different human, he hypothesized that maybe the baby is putting out some of the cells which are quite different from the mom. And that was the hypothesis, and they actually tested the blood, the peripheral blood of the mom, and they did find, to their surprise, that there's a cellular-free DNA, which is DNA which is outside the cells, which is originating from the baby itself. That led to the non-invasive prenatal testing in detecting Down syndrome, trisomy 21. That also led to oncology, where they hypothesized, well, if there's like a growing cancer in a body which has a different set of rules, different set of mutations, maybe we can try to derive it. And that's led to the liquid biopsy, which has been helpful in not just monitoring of the disease, in figuring out how the patient is responding to the treatment, trying to establish a baseline before the treatment, and trying to monitor the same cellular-free DNA at a much later point. So we tend to get a baseline initial ctDNA testing during treatment, and we tend to follow pretty significant circulating tumor DNA levels. And then it also helps in trying to recognize any resistance and figuring out sometimes the cancer does evolve in changing based on the treatment which you give to the patient, and it evolves into different mutations altogether. And that would mean changing your course of what you want to do with the treatment. And it also helps in surveillance, especially when scans are saying one thing, that there is probably a progression, when you also kind of correlate it with the circulating tumor DNA. So, and also just a quick mention of germline testing, or the genetic testing, where we have acquired or somatic mutations, where patients tend to acquire mutations which makes the cancer cells grow, but there are only around 5 to 10% of patients where there's a genetic underpinning, where there's particular genes, the more commonly known, the BRCA1 and 2, the Lynch syndrome, the HNPCC, they tend to, which cause colon cancer. So, I mean, but we tend to identify that. But again, with all that what I just spoke, it doesn't also mean that we tend to recognize the targeted treatments which are available for every treatment. That's just not the case. We still have to rely on the bulk of the backbone of treatment for cancer, which still relies on chemotherapy, radiation, surgery, the regular cytotoxic chemotherapy. But the good thing is we're identifying more and more mutations. As things have changed, as I showed you in the last slide, we're knowing more about how cancer is evolving. And now cost and access, at least all this talk, and I have to mention this, we can't go past this. I mean, there was difficulty and pushback previously from a lot of insurance companies, but now it's become mainstream and more prevalent. I think insurance companies have finally, it has dawned on them, I think, to see how important it is for taking care of patients. So I think this is probably the most important slide. So I talked about all of this just so that I can bring home this point as to what has happened with this patient. So this is an actual patient. She's an 84-year-old, which I didn't actually mention here, but she's an 84-year-old patient with a stage 4 non-small cell lung adenocarcinoma. She had a MET exon 14 skipping, where it's a particular mutation where the DNA tends to be skipped, making almost like a gas pedal being turned on all the time, and that leads to like a signal where your cells constantly keep growing. And so the reason I wanted to bring this on is the same diagnosis, it's like different fates and different times. 2008, the same patient, we would have given chemotherapy with carboplatin, pemetrexed. The overall survival was around 12 to 13 months, which usually has the side effects from the chemotherapy, which we know about. The same patient, had she been born, like diagnosed in 2017, she would have had chemotherapy plus immunotherapy, which by itself was a big jump in terms of overall survival to 20 months. But she was diagnosed in 2025. So this week, we detected that mutation in her tissue and blood right at the time of diagnosis, and that led to her to be on capmatinib, which is a MET inhibitor. So she's not on chemotherapy, she's just on the pill, and she's doing really well. She is continuing with her gardening, she's continuing with her day-to-day activities. She wants to get me honey sometimes. And she's a very sweet patient, and she's really excited. This is something which I really want a lot of patients to understand. Things have changed significantly, and I just wonder, sometimes I'm looking at this patient to see how different the treatment would have been at a different time. So same patient, different fates. So I mean, I don't know how much time I have with the breast cancer, but even with the breast cancer, so things have changed significantly. We had the 2015 endocrine area where we focused on trying to reduce the estrogen levels with tamoxifen AIs, and in the 2020 with the risk-tailored therapy, where we detected patients who had a high risk of breast cancer, and which in turn ended up getting chemotherapy. And in 2025, we fine-tuned that even more in detecting patients who had even higher risk among those patients who had high risk. So that led to a more effective treatment for those patients that with CDK4/6 inhibitors, which are targeted treatments. And that has led to increased overall survival. So I wanted to at least, this is another patient, age 48. The same patient, 2015, she had chemotherapy followed by, she had hormone receptor positive, HER2 negative. 2015, she had chemotherapy followed by tamoxifen, which is a standard treatment after surgery. 2020, we recognized that she's a high-risk patient and she would benefit from doing chemotherapy first. And then for surgery, followed by aromatase inhibitors, which was pretty much the way to go. But then 2025, as I said before, we identified that even a higher fraction of those breast cancer patients who would benefit from CDK4/6 inhibitors. So we used the pills after the surgery, which led to a surprisingly high overall survival. So meaning that we know patients who are at a high risk who would benefit from even more intensive treatment with the targeted treatments. So, I mean, that's how breast cancer has evolved. More specifically, we know how to de-escalate treatment in lower risk patients and be more effective in higher risk patients. So, and this is more directional way of looking at it. So hormone only, back in the 2015, we had a 60% DEFS. But they're not objective, but directionally they're correct. Genomic assays, which has led to slightly improvement. More now with the targeted therapies, the disease-free survival has improved up to 90% with the more early stage breast cancer patients. So this is like putting together both the breast cancer and the lung cancer we just spoke about. So we were able to risk tailor the adjuvant therapy, which is the treatment after the surgery, specifically for higher risk breast cancers. Meaning that more time disease-free over time, as molecular testing has improved, so more the adjuvant treatment options. Now, there are more other emerging targets, more specifically in breast cancer, PIK3, ESR, HER2 low, germline BRCA1, which would require more treatment options. And the interesting thing is the HER2 low expression, this is now classified as a tumor-agnostic treatments, meaning for a stage 4 or any other advanced cancer, really doesn't depend on anatomy. This the biology. If that particular cancer has a HER2 low target expression on IHC, we can give treatment with trastuzumab or Enhertu or trastuzumab deruxtecan, and it is quite effective, regardless of where the cancer may have started off from. So now the future, what's coming next? So this is CAR T cell therapies where you engineer your own T cells, your own immune system to be primed to recognize the cancer antigens and send them back to attack the cancer cells. It's already being used in heme malignancies a lot, lymphomas and myeloma, and it's being quite effective in treating it. And they're also trying to use it for solid tumors now. Now, personalized cancer vaccines, they're also trying to use neoantigens so that the vaccines that are given are much more specific to the cancer itself. And there are other things too, the multi-cancer detection. Let me go back here. Yeah, multi-cancer early detection, where they can actually, they're in the verge of, we're trying to find out if certain blood tests can screen for dozens of cancers simultaneously, but still we're in the early phase for that, but I think that's something which will be quite exciting. So these are all the resources which will be helpful if needed. That's pretty much it for 15 minutes.
Thank you. That was a lot of information. Does anyone here think that they need to go back to night school and take a genetics course? It's pretty amazing what things are happening here. Dr. Schwartzberg, would you like to enlighten us more and tell us more about good news? Well, the one thing I also want to say is, that one slide about breast cancer, it's almost like over a 90%, quote unquote cure rate now. It's unbelievable. Yeah, it's unbelievable. Thanks.
Thank you. Thank you so much for inviting me. It's always a pleasure to come down here and talk to a community that is interested and informed. And I'm going to actually continue what Dr. Bijjula talked about and come at it from a slightly different angle and hopefully make this very complex area a little bit more understandable. And we're still learning. I've been doing this for several decades now, and I've never been more excited to be a medical oncologist. And when I wake up in the morning now, I go to work, and I'm excited about seeing patients. And why is that? Because patients are doing much better, as you just heard. And there's been an evolution over the decades, and particularly in the last 10 or 15 years, because we understand the biology. So I'm going to make this little audience participation. So December 1971 was an important month and year for cancer. Does anyone know why? You don't get penalized if you're wrong. So, okay. Well, December 1971 was when President Nixon signed the National Cancer Act, and that was when the country made an informed decision. Talked about putting a man on the moon. And, when we did that in 1969, we had less computing power in all of NASA than you have in this right here. And yet, it takes longer for cancer because you heard it's biology as opposed to an engineering issue. And we still are understanding biology. So in 1971, the funding increased dramatically. And there was a lot of sniping in the 70s and 80s. Where are the solutions from the Cancer Act? And then in 1991 was an important year, too. Does anyone know why that one? In 1991 was the peak of mortality from cancer. And since 1991, every single year since then, there's been a decrease of about 1 to 2% in mortality. So it took 20 years to get to the point where we started to make a difference, but the curve is going like this. Now, the number of patients getting diagnosed, as you heard, is still going up for other reasons, environmental factors and other factors, but the mortality from cancer is going down. Overall, it's down by about 40% from that time. And that's because we understand the biology and we've been able to do precision oncology. So I'll continue the discussion, the nice discussion we heard. So what is precision oncology mean? It basically, you can mean that we're tailoring the treatment to the characteristics of each patient's disease. And that goes beyond just the anatomy, although the site of origin remains important, but also that we give the right patient the right drug at the right time. And the success will be, in order to do that, we have to have good diagnostic tests to tell us what the right drug will be for the right patient at the right time. So we'll go into a little more of that. So cancer genomics, Jim Watson died this week. Jim Watson, anyone know what he did? Oh yeah, what did he do? That's right. He had the structure of DNA, the familiar double helix, and the building blocks and the alphabet of life, which is based on 4 letters, TCGA, right? Those are the initials of the 4 bases that are the code that make up our genes. And we have 3 billion base pairs, it's called, in every gene, in every cell, which are condensed into chromosomes and so forth. Okay, so that was in 1951. You see that there, the description of the double helical structure of DNA. So 2001 was when the first human genome was fully sequenced, 3 billion base pairs. It took about somewhere close to $1 billion to do that. It was the first experiment in big science that was done in the biological space. And that was only 25 years ago. Now, if you look there, you see the first cancer genome was around in 2008. So we didn't even know the spelling of a cancer genome until 2008. Now, this slide is from 14 years ago, and it was the 10th anniversary, actually, of the first genome. And as you can see there, it says, in the last box, cancer genome sequence as a routine diagnostic in 2020, and the prediction was correct. It is a routine diagnostic now. It does what Dr. Bijjula was talking about, is how do you find the right drug for the right patient? I'll explain a little bit about that. So there's a whole bunch of different kinds of alterations in genes, and I'm not going to quiz you on these, but all of these different characteristics can be found now from relatively simple tests. So, oops. So it turns out there's a lot of genes that are so-called cancer genes. There's about 300 cancer genes of all the genes that we have, about 20,000. And those genes are either called driver genes, which means they rev up the cancer and they make it more cancerous, or suppressor genes. And we're born with genes that their task through life is, if one of your cells goes awry and starts becoming rogue, as you heard, that it shuts it down. That gene is actually the most common gene that is altered, called TP53. So if your master brake switch gets messed up, it allows your cells to start becoming cancerous. And then there's a whole long list of potential targets there. Those are all the names of genes that are either driver or suppressor genes that potentially we could find drugs to work against. Yeah. So the key principles when we're thinking about how we use genomics to treat cancer are that we know these genes are important, and they're important in the pathways in the cells, the circuitry of the cell that makes the cell become malignant. And many of them, as you heard, are druggable, meaning we can find drugs for them, like you heard about HER2 and BRAF. Some of them are currently not druggable, but they're getting better all the time. And sometimes it's like a series of on-off switches. You want to try to turn off the top master switch, that's HER2 in breast cancer. But you could also turn it off further down in the circuitry. So we're learning a lot about the circuitry. We still have a lot to learn. And biology is really complicated. That's one thing I've learned, but we're making progress all the time. So I mentioned $100 million to $1 billion, that's a little, to cost to sequence a genome with the technology. And there's a thing called Moore's Law, which is how many transistors you can put on a chip, which made our computers so good that it kept going down. You could double it every year, and there's now hundreds of millions of them on a chip. So look what happened with the cost of sequencing DNA. It kind of went along with Moore's Law, which was really good, but it's accelerated much further. And now the raw cost of sequencing your entire DNA is less than $1,000. It's a few $100s just to sequence your DNA. And in the future, I predict that medicine will be practiced, not just cancer, but all medicine will be practiced with knowing the sequence of all of our DNA and using it. It's not the answer to every problem we have by any means, but it is very informative. So we're not quite at that point yet, but we will be soon. So the size of the panels of the number of genes we can look at has grown, and now we look at all those genes. Okay. So I wanted to, this was kind of mentioned, but I just want to back up and so you understand what we're looking for. We're looking for what are called biomarkers. What's a biomarker? It's a test that identifies patients likely to benefit from a therapy. It doesn't have to be a genetic test. It can be an imaging test. It can be, there are other technologies, but tonight we're really talking about focusing mainly on genomic tests as biomarkers. So there's a lot of different biomarkers. It can tell us which patients are going to be helped by a therapy. It can also tell us which patients are going to be harmed potentially by a therapy. And we can monitor patients. And this can be in DNA and RNA and protein and other substrates as well. Okay, so just a little history about what Dr. Bijjula was talking about. The first targeted drug that was developed was in the late 1990s in rituximab for lymphomas initially. In 1998, trastuzumab, which you heard about, was introduced for HER2 breast cancer. I happen to have been involved in the two seminal trials, got both those drugs approved, and in those days people were like, that's ridiculous, you can't use an antibody in cancer, we have to use toxic chemotherapies. And these trials took a long time to get done, actually, because people didn't believe that, they believed that the dogma, it was correct, and what I learned over the years is that you have to be very flexible in your thinking because new things are always evolving. So that happened. The first drug for CML that actually cured CML, chronic leukemia, imatinib in 2001, and we were off to the races after that with lots of drugs approved, as you heard. Can't get my slide to go there. So this is just an example of 3 years of approvals by the FDA or in the UK on the bottom of all the drugs that were approved just through those 3 years. And I could have extended this to 2025, but I wouldn't have been able to fit it on the slide. So they're all, every single month, there's a new targeted drug or more approved for a specific alteration. And we currently use the kinds of sequencing that are in the red box there. There's a lot of different technologies. They don't really matter, but we use what's called next generation sequencing, and we can do that either from your tissue, your cancer tissue, which we take out, or biopsy, or from the blood, and we'll talk about that. And today, actually, we do both DNA and RNA sequencing, and we get information from both of those. So we can either use tissue that's been taken out and in the laboratory, that's in wax, that's called FFPE, which is mainly what we use when we're talking about tissue, and that's kept. Some people, I said this to a patient today or yesterday, that, we can go back to your tissue, it's kept. It's a law that you have to keep any cancer tissue for 10 years at least, and they're in little wax blocks. So if you've ever had cancer, your tumor's stored, and if we make a new discovery and you want to do another test on it, it's there, and that's been immensely valuable for some of the work. We're moving now into blood, and I wanted to talk just for a minute about what the so-called liquid biopsy, which is really transforming the way we think about cancer and how to manage cancer. So tissue biopsy is always important because that's how we tell you have cancer. So if you have a mass in your breast, we usually do a ultrasound-guided biopsy and get a little core of tissue or several cores. That's enough for the pathologist to look at and say, yes, this is breast cancer, it's this kind of breast cancer, and we can test for estrogen on that with a protein test, a little stain, stains brown, compared to the other cells, or if it's negative, it doesn't stain brown, and so forth. That's called the protein testing. And we can also use that same tissue for DNA and RNA biomarkers like we've been talking about. One problem with that is, if any of you have had a biopsy, it's not the most fun thing in the world to go through. And you can't just do that every month or every 3 months. It becomes progressively harder, and it becomes progressively dangerous. So that's the problem. However, it's really critical to make the diagnosis. But now we have liquid biopsy, which is minimally invasive. It's your blood draw. And it can be as little as 1 tube of blood to give you vast amounts of information. And you can capture, it's very fast. It takes about a week to get the result there. But it does have some disadvantages too. So today, this is what we do. We have a patient with cancer. We do liquid and tumor samples. We get all that DNA and RNA and protein information, and based on that, we design a treatment. If the treatment works, we keep watching it. If it doesn't work, then we re-biopsy with the liquid biopsy, and we come up with the next treatment and the next treatment. So that's how the current system is being employed. This is just to show, this is an article, a study we did, published a couple of years ago, looking at, I won't bore you with the information, but basically the idea is liquid and tissue are complementary. In other words, sometimes you find it in tissue and you don't find it in liquid. Sometimes you find it in liquid, you don't find it in tissue. So today, I think most of us use both of these with a diagnosis of advanced cancer to try to find out all the information from the genes so we can use it effectively. So as you heard, ctDNA has been here for a while, and this is sort of a timeline of it, but it's really accelerated over the last 5 years. So this is really something that people weren't even talking about 10 years ago. And today it's pervasive because it is such a powerful technique, and we've been able to translate the biology into finding things in a single tube of blood. And just to give you the schematic, what you heard about already, you can use it in different places. You can use it at diagnosis. You can use it after surgery. You can use it to monitor the treatment we give after surgery. You can use it for advanced disease to pick the type of treatment, or you can monitor the treatment response and pick new drugs. So it has a great deal of information and utility, clinical utility. In fact, there are some things we haven't able, the technology has moved so fast that we haven't even been able to do the studies to show it really makes a difference in some cases. So there are many different, in the interest of time I'll go on, there are many different tests. They're getting better all the time. Right now, we can pick up one DNA molecule of tumor in your blood. I'll say one other thing, just so you understand that a little better. Your DNA is shedding into your blood all the time, normal DNA. As your cells die and divide, all of our cells are undergoing, our bodies are very active. Every tissue in the body is continuously making new cells. Cells are dying. That's part of life. That's just the way it goes on. And when those cells die, they release some DNA into the blood. So this is truly a needle in a haystack. You can pick up one molecule of tumor blood in 1 molecule of DNA in 1 ml or a teaspoon of blood. That's how sensitive it is today. So there are different platforms. I won't go into that. It's a little complicated. So the question is, this is what we get. This is what you think about every day. Doc, how do I know if my cancer comes back? What can we do? And most people ask for PET scans. Well, PET scans are really not good tests for finding small amounts of cancer in your body. By the time you can see it on a PET scan, it's already clinically apparent, and you're in a different situation. But today, using liquid biopsy, we can now find molecular evidence of cancer before the scan turns positive, which could happen 6 or 12 months later. And the real question, and it's not answered, is if we intervene early, we get a molecular test that's positive, and you change your therapy then, does it translate into an improvement down the road? And I can't stand here in front of you and say we've definitively proven that yet, but there are hints that it might be true. And this is a study that looked at one of those drugs Dr. Bijjula was talking about that showed that if you were negative and you stayed negative with liquid biopsies, you had a great prognosis. But if you were positive, even when you start, and you never turned negative, that your prognosis wasn't good. And therefore, we should get new strategies about how to treat patients in these different groups. And a lot of studies, this is to show you that we're doing lots of studies right now to use ctDNA as guidance of how to treat patients. So in the next few years, you'll hear about these results. And I'm optimistic that liquid biopsy will help us take better care of patients because we'll have an insight into what's happening at a level we haven't been able to do before. I went back. Oh, I'm going the wrong way. Oh, yeah. So that's what we're doing now. This is just one study where we're surveilling patients every few months to see if it changes. And this is the same thing. We can use it across the spectrum in any cancer, really, not just lung cancer. And next slide I'll pass. So the future of molecular testing is here tells you about tissue biopsies, and there's many other things we can look at and will look at in the future. Won't go into detail, but as we learn more about the inner workings of the cell, we'll be able to do more. And liquid biopsy isn't just limited to DNA, actually. There's a lot of other stuff in the blood that we can look at in the future, including circulating tumor cells and proteins and subcellular organelles called exosomes. All of these things have information. We just have to learn what the information is good for and how we use it to treat you. We can already test those things. And the last thing I just want to mention, so AI was brought up. We really don't have time to get into AI at all, but I will tell you that AI is in cancer medicine today. Right now, it's mainly focused on improving imaging and improving pathology, which it's uniquely suited for because it can look at a vast amount of information and drill down into things that human eyes sometimes will miss. So that's where we're using it today. We're using generative AI to help us do research studies, to design new drugs, and of course, in the future, AI will be pervasive in the use of cancer medicine, all medicine, of course, and we expect good things from that part of it. So it'll really be incorporated into every aspect of the patient continuum, all the way from prevention through end-of-life care. So that's a whole other seminar maybe we can do next year and talk about AI. I'm inviting myself back, so, you know. So precision oncology using these biomarkers is the new standard of care. This is not the future. This is the present. And these tests are getting cheaper and better all the time. And that's in part also because the bioinformatics around the understanding DNA, it's not just knowing the spelling of the letters, but what the meaning of the words are that they spell, and that's what we're learning. And other platforms are coming along. So this is, if you didn't get the impression from both of our talks, this is really very complicated for the practicing oncologist. If lung cancer is 20 different diseases, which it is at least, each of which had one of those specific mutations, and then within that mutation, you know, was it this base or that base, a little different drugs work, you can see why it's becoming increasingly difficult to be a generalist in oncology. When I started, I saw everything. You know, I gave the same chemo to half the patients because that's all we had at that time. And it didn't work very well. But today, it is so specialized that it becomes more and more difficult. I do think AI helps us there in helping to determine best treatments. I'm hopeful that it will because there's just too much knowledge for any one person to be able to keep in their head or even to access from patient to patient. So it's a good problem and a bad problem, but hopefully we'll have ways to solve that one in the future as well. So thank you, and I think we'll take some questions at the end. Is that right? Okay.
certainly seems like a brave new world in cancer treatment and diagnosis. But one thing I want to emphasize what Dr. Schwartzberg said, if you've had a tissue biopsy, don't let that 10 years go away. Go to the hospital and get your specimen, put it in a shoebox in the closet, because, you know, every month there's new technology, there's new things that are being done, so keep your tissue. Now, I don't know what you're going to do with the grandkids or the kids when you pass it on, but keep that tissue. So next we're going to have Lindsey Foxen, who's a clinical oncology nurse, who really is the heart and soul of cancer treatment, who directs us through the therapy and information and all the resources. So, Lindsey.
Okay, let's see. Anybody understand any of that? Because took me a long time to understand what they were trying to explain there. Okay. All right. So you were just diagnosed with cancer. This is probably what's kind of going on in your head. It's a new vocabulary. The doctors gave you a diagnosis. You hear cancer. But then genetic testing, which they spoke a lot about tonight, targeted therapy, radiation. What does it all mean, right? That's when you get to meet me, and hopefully I can help guide you through this process, because it's busy, it's a lot, yeah, sorry, and it's scary, so. What is a nurse navigator? So technically, I am a registered nurse who specializes in oncology, and I serve as a consistent point of contact, ensuring that the patient never feels alone in this journey. I bridge the gap between patients and providers, helping ensure that care is seamless and patient-centered. Education is a big part of my role, and I educate families and patients about the diagnosis and the treatment that they may have to undergo. A lot of our treatments are not just chemo anymore. It is immunotherapy, and it is a lot of oral pills that people don't really talk about or maybe get the education. The doctors will be like, oh, you have this mutation. You qualify to just take an oral pill. I'll send in the prescription, and good luck. And they don't really get educated on it. They don't really they'll follow up with the doctor, but they may undergo side effects, and it's like, am I supposed to feel this way? Am I supposed to, they have so many questions with the oral aspect of treatment. So it is really, really crucial that they reach out to their nurse navigator and ask those questions. And we are available for them for those questions. We're here to advocate for the patients and their needs, and support emotional and psychological well-being as well. Let's see. Let me go back 1 minute. So another part of my role is to coordinate multidisciplinary care among physicians and support staff. So I am your main person, I am the middleman. Your physician will tell you something, and then I will run with it. So if you have questions with the multidisciplinary team, so a lot of times patients may be referred to surgery or radiation oncologist for treatment, and I will be that person to kind of communicate with those other physicians and parts of that multidisciplinary team, and help answer any questions along the way. Pretty much I'm there to streamline the cancer care journey. I am the glue that holds this multidisciplinary team together. Yeah, thank you. At least I try. My point, I want to prevent delays in any treatment or diagnosis. So that comes with your scans, imaging, labs, I don't want the doctor to put an order in and then you call me and you're like, well, I can't get in for 3 months. No. No. I need to know that. I need to make sure that you are getting in for those scans in a timely manner so we can make that diagnosis and get you on the correct path for survivorship. There are tons of barriers with cancer, financial barriers, just family support or support from others. It's scary, and it destroys a lot of, it takes away from the person as a whole. Like we take it away, they are no longer really in control of their life. And it's scary to be like, okay, here, you can have my life for the next however long the treatment is. Please take care of me and do it well. So it takes a lot of trust, and you want to trust your team to be able to give that up for that time. Oops. Oh, no, that's not what I want, sorry. I get asked a lot of questions every day, and most of them are really, really good questions. I do get questions that I cannot answer, nobody can answer. But really, what does my diagnosis mean? As you heard with our oncologist, did anybody understand really what they were saying? What does it mean? How long do I have? That's a tough question, because we can know if you are going to be curative or potential curative in your state, or if we're going to just be treating you palliative. But even palliative, which means your cancer will never go away with treatment, but we can keep it at bay for a pretty good amount of time of life. So that's a hard question. And it's a question that a lot of patients don't want to bring up to their physicians. Actually, when they see the physician, they're doing great. Everything is great. I feel great. I love my treatment. I just can't wait for my next cycle. Literally 2 minutes later, they walk in my office. I'm vomiting. I'm sick. I can't go on any longer. How much longer? It's a completely different story, it's okay. That's what I'm there for. How am I going to feel? Well, you're not going to feel good. Imagine drinking Clorox. You're not going to feel great, but I can get you through. We can get you through. There are supportive medications. There's that we can get you through the treatment as long as we know what's going on. If you go home and you're like, I just don't feel good, and we don't know, then you're going to be too sick to the point where it's like, okay, now we're in now we got to do something big. How long before I experience side effects? And how long will side effects last? Will I lose my hair? Not necessarily. Not everybody loses their hair. Side effects, they last usually a good week after treatment or so, depending on your treatment. Everything is very it's not chemo. When somebody says you have chemo, I'm getting chemo. It's not chemo across the board. It is becoming more specialized. It is more designed for you. It is based on your body, your height, your weight, everything. So we don't know until you give it a try. And the good thing is, if you don't like it and it's not for you, we can try something different. So there's all sorts of ways to make it easier for you. Let's see. So why do nurse navigators matter? Well, research has showed when patients do have a nurse navigator, somebody that is part of their journey, it improves both patient experience and outcomes. It improves care coordination and patient satisfaction, and increases the treatment adherence and timely care, and enhances quality and outcomes and reduces disparities. So in conclusion, navigation is the heart of oncology care, and navigation ensures no patient falls or faces cancer alone, ever. So thank you.
Thank you. No, we've seen this, the science of cancer, but the human side of cancer. We've seen the science of cancer, but the human side of cancer still is probably the most important part. So we have lots of questions, and so we'll try to get through these. The first question is, how were the recent federal funding cuts to healthcare impacting cancer research and patient care?
Yeah, I can start. So around the country at academic centers, there has been a big impact of the cuts and the uncertainty. And so it's been more the uncertainty as it relates to cancer. The National Cancer Institute has been cut in some areas, somewhat less than some of the other. The National Institute of Health is a huge umbrella term for multiple different programs within it across the entire spectrum of human health. And cancer has taken a little bit less cut than others, but the government shutdown and reductions in force have led to a lot of people not knowing where their grants are going to be, and grants are the lifeblood of research in the academic community. So it's an uncertain time. I think I'm particularly concerned about the next generation because, to be honest, being an academic researcher is not a great lifestyle. You're always dependent on these grants. You're not paid very much. It can be difficult to get a grant funded. Even in the best of times, you might be surprised to hear this statistic, but when you submit a grant to the NIH to be funded in any field, only the top 8 or 9% of those grants actually make it through to actual get funding. And others have felt to be very valuable to just the amount of money there is. And that's peer-reviewed grants. So now it's down to 3% as of today. So it's an uncertain time, and hopefully it'll stabilize.
Yeah, I think I completely agree with that. I've spoken to some of the University of Utah, academics, and they did tell me there was a significant cutting in grants, and at the same time, I think, as far as I know, it was almost 24 of 25 applications had been rejected, and for financial year 2026, there's a reduction of around $2.7 billion of funding overall. I think even for financial year 2025, I think around 5 to 7% of what was originally planned for. I think the other important thing to remember is also the Medicaid. I think the federal funding, I think moving forwards, I think there's going to be cuts for Medicaid, and I'm not an expert in this by any means, but it just seems like it's going to be a lot more challenging in terms of administrative procedures moving forwards next year.
So, we're in northern Nevada. We're not in a major urban area. What are some of the challenges do you guys, all of you, face in your practices?
Yeah, so I think compared to Maryland or West Virginia, where I was from, when I came from, I think it does seem like it's a lot more difficult to get things done in a timely manner here. And that could be just because of getting the biopsies done or scans done. It just seems a little bit challenging. I think there are many reasons for that. I think one of the big reasons is the amount of population, it's how dispersed it is over here. There's a lot of disparity between rural and urban here. A lot of population is obviously in Nevada, is in Reno, and most of the academic centers, most of the specialized cancer centers are near to Reno or Vegas. And one of the facts to remember is that it's in the rural areas, even though the number of new diagnoses of cancer is low, there's a higher risk of death from the same cancers. So that just tells me that there's not enough screening, there's not enough early detection of cancer, which needs to happen. I think, and also, if you look at the Nevada budget, I think Medicaid alone is around 25% of the whole entire Nevada budget. So that just tells how much the state is trying to keep pace with the healthcare here.
Yeah, I agree with all of that, and the rural population is clearly an underserved population, and many patients unfortunately come to care at a time where their cancers are more advanced and sometimes not curable. When if they had undergone early detection with screening for the cancers that we can do, they would have probably had a better outcome. We do a couple of statistics. We're actually at the bottom of the barrel for statewide, for states rather, for lung cancer screening, which is a standard modality now that we use. And so we're very low. Trying to make progress with that with the Nevada Cancer Coalition, which is a statewide organization that all of us belong to, and we've made a little bit of improvement, but there's a lot of work to do. So better screening. We do pretty good, actually, with mammography. We're sort of in the average there, so, and even in the rural areas. But the other screenable cancers, we haven't done as well. And this late diagnosis is clearly an issue, and timely treatment can be an issue. Once they get to us here in Carson or in Reno, we can move things along. It's really that transition from the community to the cancer center.
So these new targeted therapies are pretty expensive. Can you give us a sense of what the costs would be with some of these newer targeted therapies? And are you having any difficulty with coverage with insurance or?
Yeah, that's
Yeah.
it's a very frustrating area. I don't think the system has gotten any better over my career. I think it's gotten more complicated. So, you know, there's a lot of different prices there because there are a lot of different middlemen in the huge industry that is healthcare today in the United States. And it doesn't seem to, my personal opinion is it's not going to get reformed anytime soon, although there's been a lot of efforts to do it. It's a very complex system. Targeted therapies are a fortune. I mean, no one pays the list price, though, okay? So the list price of a drug, one of those checkpoint inhibitors is $10,000 a month. So who here has an extra $120,000 to just, you know, put on that every year? And no one has that, but no one pays that price, and it's kind of a shell game. And in the end, the manufacturers are good at providing care for people that have astronomical copays, but it's a lot of work to get to that point and do that. We have staff that do nothing but financial advocacy for our patients. So that's on us, that's on the hospital, that's on a practice to employ people whose job is to navigate these complicated foundations or assistance programs or insurers or what are called PBMs, which are pharmacy benefit managers, which everybody hates, but we can't get rid of them yet for some reason. I mean, really, we're all united. It's not a red or a blue thing. The bill's been in Congress. Doctors are against it. Manufacturers are against it, except you know, the insurers. They like it because they own the companies and they get an extra 2 or 3% out of that. So it's very complicated.
Yeah, it's a big challenge. But I think at least the silver lining to it is I haven't had any patient who did not get it. I think it's been a struggle sometimes to actually. But once it's done, it does seem to take some time. But I've had drug manufacturers themselves try to give the medication by themselves. So I mean, it's been a struggle, but a lot of times the patients have gotten the medication.
Yeah, but I mean, it is important. You can usually get it, but we also know that that medical bills, and particularly oncology bills, are the #1 source of bankruptcy in the United States. So it's a problem.
Yeah, I mean, I have patients every time they come to me that talk about the medications, and I don't know what to tell them.
Yeah,
it's something which we have to go along with what's happening, but I mean, I don't know how to even do anything about this.
Yeah, advocacy is really important here. So we advocate, and I will tell you, we come down to Carson. We have the Nevada Oncology Society, which is our professional association, and when the legislature is in session, we come down. We passed a biomarker bill. You heard about biomarkers. 2 years ago, we passed a bill that mandated coverage by insurance for biomarkers in cancer, and that was a big accomplishment. So there are bills out there, and you know who they want to hear from, the legislature? Not me, not us. They want to hear from you. And just keep that in mind for the next session. If you're interested, there are always bills that we'd like to advance and make things easier, particularly from the financial perspective.
That's great news.
Yeah.
So there's a number of members of our audience who have family histories of cancer, Lynch syndrome, ovarian cancer. How does one request and get molecular testing or genetic testing?
Yeah, how do you do it?
Yeah, so it becomes easier when there's like the patient when the patient himself or herself has a diagnosis of cancer, the index case. It just becomes easier to start the process from then on because the insurance pays for it. The problem we run into sometimes is when there's no diagnosis of cancer, but we do know that there is family history of cancer, then it becomes challenging. So you either from a Medicare standpoint, they don't do as much preventative measures. It's more about treating the disease once it happens. So and then from a private insurance standpoint, even from an Affordable Care Act, the mandate is that it does tend to cover, depending on the discretion of the insurance. They also very particular about just covering just for the BRCA1 and 2 mutations. They don't really cover, let's say, if it's a male patient, male breast cancer, it doesn't cover for other conditions such as Lynch syndrome. It doesn't cover for other mutations outside of the BRCA1 and 2, which is like, let's say, PALB2, CHEK2 mutation, which are still quite important in terms of risk of breast cancer or other cancers, but it still doesn't do that. So the best way to sometimes go about this is to actually speak to a genetic counselor, then start the process, because then they can take a detailed pedigree history and try to make a best case for this to pass through insurance. If that doesn't happen, then either we're facing an option of the test being covered just for the BRCA1 and 2, which may be covered by the insurance for like $0, or sometimes we would prefer like a multiplex genetic panel, which would involve multitude of other genes, which is really the right way to do, but it would cost like less than close to $1,000. So either we're stuck with trying to get a partial test, which will really not answer the question, to getting a more expensive question, which is a much more comprehensive one.
Yeah, that answers it nicely.
So after seeing this presentation, I'm really, really scared about cancer. I might get pancreatic cancer, leukemia, lymphoma, you name it. And there's a lot of commercial sites that are advertising screening for cancer. It used to be 23andMe, but it could be Infinity, et cetera, et cetera. What do you guys think about that?
Yeah, so a couple of things. This is becoming an emerging issue for sure. So in Reno, we have billboards for get an MRI, get a whole body MRI, and there's no evidence that really helps you with diagnosis. It does earlier, and that you live longer if you do that. So I don't recommend that. The biggest problem with getting MRIs is they find lots of things that turn out not to be cancer, and people get needles stuck in, and sometimes they get some bad reactions to things that really they didn't need to know about. So I won't say, it's a dynamic area as far as imaging goes, but I would not do routine imaging to look for cancer. I don't think that there's a shred of evidence yet about that. Now, what's coming out, and it was mentioned, but we didn't talk about it in detail, is what's called MCED test, multi-cancer early detection test. You might have read about that. There was just a big presentation a couple of weeks ago on the first test to do that, although there are many in the field now because as we showed you, the technology has improved really, really fast, and it's getting better all the time. So what these tests do is, in a tube of blood, they can find up to 50 different types of cancer. But importantly, they can find the cancers that we don't screen for. So we screen for breast, cervical, lung, colon. Those are the cancers we can screen for, and screening done right definitely does save lives in each of those instances. But we can't screen for pancreatic cancer, like you say, and although most of it is not hereditary, we just don't have a good way of screening for that, or stomach cancer, or many of the other cancers. And in average risk populations, you can't. So what these tests do is they can find the cancer. The problem with them today, in 2025, late 2025, it will be different in a year, they don't find early stage cancers all that well. They can find stage 3 and 4 cancers, and that's already advanced disease, and it's unlikely finding those a few months earlier in asymptomatic people are going to change the natural history. So we need better tests that identify early cancers, or the cancer that is most along in this field, and I do a lot of work with industry in this field, so do kind of know what's going on here, is colon cancer, where you can test. There are blood tests now, there's stool tests, which you're probably familiar with, and there's, of course, colonoscopy, which remains the gold standard. But you can do tests in the blood, and what they're really trying to do, and they have not done it yet, is find precancer lesions, which are called adenomas. And some of you may have had adenomas taken out, and that's great because that's your gastroenterologist taking out a lesion that would likely have become cancer. So that's an active thing. Now, if you pick that up with a blood test, then you could go to your gastroenterologist then. Those tests are not good yet. They only pick up about 10% of advanced adenomas, and they pick up about 30% of stage 1 colon cancer, and they are good with stage 2 through 4. But again, the higher the stage, the less benefit you're going to get from getting it from a blood test. So keep an eye on it. You can get a Gallery test from Grail today for the low price of $980 if you want to do it. But they find, they do find cancers. They're rarely wrong. They're rarely false positive, but their false negative rate is still kind of too high. So for the average population.
Thank you. So what is the greatest misconception about cancer that you feel is out there in the public?
Question. You want to say?
There are quite a few. I think
It's a difficult question.
I think the first one would be like saying that cancer is a death sentence. That's probably the biggest question. I think there's obviously, understandably, there's a lot of fear. So the survival, the length of, it really depends on the type of cancer, the staging, and also now with the biomarker testing, there's so many other variables which get into the objective answer. How is the patient himself or herself? How is he able to tolerate the treatment? So there's no one answer. But in the same time, the one thing to at least remember is there are 18 million cancer survivors in the US right now. So, that just tells, that's what, 3%? Just a quick math when I think about it, it's around 3%. So, so that just tells me that that's quite, that oncology treatment has improved. People are tending to live longer, even when you look at the more important lung cancers or especially breast cancers. So it just, I think that's probably the biggest thing to dispel.
Yeah. Okay.
I was going to agree with him. Definitely, they think I'm going to die. So.
And so it's surprising for some people to hear. I treat a lot of breast cancer, and to hear that the cure rate for early stage breast cancer is very high. It's over 90%, and it depends on what time frame you're looking at. But the chance of dying of breast cancer, if you have a stage 1 cancer, is very low. It's very low. So early stage is important. And the other end of the spectrum is also important. So we now think about most cancers when they are advanced, if you come in with stage 4 or metastatic disease, or if it comes back, in the minority of patients it does. And again, it's different from a pancreatic cancer and a breast cancer, unfortunately. We still have a lot of work to do in many of those cancers. But our goal as a team is to maintain your life as good as possible for as long as possible. That's all we're there for. And we're not there to tell you what to do. We're there to work together with you and come up with a plan that meets your goals and do that throughout the continuum of the disease. And we do see recently an eroding of trust in the medical profession, and that's concerning to me because, I've worked with many people over the years, and they're in oncology because it's not always a fun profession. We're there to help people, and that's what we try to communicate to our patients.
So is cell-free DNA testing, molecular testing, genomic testing, is that the standard of care now, or is that still experimental?
So it depends on the setting. So in an adjuvant setting, let's say for a breast cancer or a colon cancer, I think they're still being studied. It's still not yet in the NCCN guidelines in terms of early stage. But I think there are trials looking into trying to find out. There are some recent trials which have looked at treating high-risk colon cancer patients in an adjuvant setting to be treated, but it's quite frequently used more like as an adjunct, especially in the metastatics line when you have scans showing that there's possibly progression. Does it add weightage to your decision-making process, or it doesn't? But sometimes we also find that there's presence of circulating tumor DNA, but the patient's doing fine, scans look great. Then how do you interpret that? So there's a little bit of I do use it quite often. I think a lot of oncologists do use it, but it's not always that it's actionable.
Yeah, and I would just add that that there are different types of tests that are molecular tests. So the one thing that should be standard in many cancers, if not all cancers today, is to do what's called a molecular profile, which is to look for those genes that potentially have a drug associated with them. That is standard of care. If you're not getting that, then you're not getting the standard of care, quite frankly. If you have lung cancer and you don't get tested with a panel to see if you have a MET skipping alteration or HER2, et cetera, then you have not gotten standard of care, period. Now, monitoring patients with what's called minimal residual disease test, as you heard, is still, I wouldn't say experimental. Actually, Medicare covers it now, which is sort of the standard. But I would say that what we call the clinical utility, what's the long-term benefit of it, is still up in the air.
Okay, so more and more younger people are being diagnosed with cancer, especially colon cancer. Do you have some ideas as to why this is happening?
McDonald's. But no, seriously, I think it has a lot to do with food, processed food. Busy lifestyle where we are not cooking whole foods for ourselves anymore. We are going out to fast food, especially the younger college kids. They don't know how necessarily to also prepare home cooked meals with whole foods. I think that plays a major part in why we're seeing, especially colon cancer, on the rise in younger individuals, is my thought.
Yeah, and just to add to that, there's something called the microbiome. That's all the bacteria that live in your gut. We all have, that's normal to have hundreds of different types of bacteria in your gut. And what we've learned, again, 10 years ago, no one was even talking about this. Now, very hot topic, and the microbiome has a role to play in the ecology of any individual, of any organism, particularly as it relates to the immune system. So when you have a lot of Big Macs and your bacteria change to the ones that like Big Macs, they may not be the ones that help your immune system all that well. And that may be part of what we're seeing.
Yeah, I think add to that, like I think MSKCC they've looked at 4,000 patients who were young and who ended up with colorectal cancer. They found that, yeah, I mean, and we have a few knowns and we have a few unknowns. The unknowns are that, hyperinsulinemia, metabolic syndrome, obesity, smoking, all of this definitely drives cancer. The unknowns were, in this particular, which they followed upon, these patients didn't necessarily have like a higher obesity in general when they followed this 4,000 patients, because one of the examples which actually comes into mind is Chadwick Boseman. I think the guy who had colorectal cancer, he died at the age of 43. So there does, I mean, it's still early to say, but there does appear to be an early distinct biological pathway for these colorectal cancer patients. Some of them are not necessarily obese, they're not necessarily eating fast food in general, but it is still early in trying to find out if this is like a different biological pathway actually causing the colorectal cancer to begin with. So this is the part of the unknowns, and I think gut microbiome is part of that. They did find in that study that there was less diversity in the gut microbiome as compared to like a regular population. And there are also environmental additions like pollutants, other environmental which can increase the risk of colorectal cancer in general.
So the next question we could spend a whole semester on, but in layman's terms, you have 2 minutes. Why do Homo sapiens get cancer? Why do we get cancer? I mean, what's the reason for it?
Okay, whoever answers that question right gets the Nobel Prize next year.
I remember
what happens, I mean, like I said, in layperson terms, why does a cancer cell all of a sudden go berserk, go rogue, like you said?
Well, so cancer, the cause of cancers is complex. I mean, in general, we think of cancer as a genetic disease. So at some point, our cells, remember, again, you have to replicate every cell and transcribe it exactly right in every cell. So it's not surprising that there can be errors, spelling errors, and those spelling errors can be in genes that are important that cause cancer. And some of it is environmental, for sure, but cancer's been around since the dawn of time. I mean, it really, in human beings. So it's not a new phenomenon of civilization, although it's much more common now than it was 2,000 years ago. And we have Egyptian mummies with breast cancer, documenting that. So that's part of it is environmental, and part of it is genetic. If you happen to be born with one of those genes, about 5 to 10% of cancers are caused by genes that are those regulating DNA genes that you were born with that don't work as well. And so over a lifetime of exposure to ultraviolet light and smoking and inactivity and so forth, that they don't fix it as well. So that's it. But why? So it's a great question in evolutionary biology, which I don't know the answer to. I do know that certain species don't get cancer. For example, sharks don't get cancer. And we don't know why, but, they have their own issues, I guess.
Yeah.
I mean, I don't have the answer to this. I'll make 3 statements. One is, one of my professors in my fellowship used to tell me, if we ever find the answer for cancer, I think we would have found the answer for immortality. I think there's some truth to that, number one. Number two, I've found babies, when they have acute leukemias in the pediatric age setting, their cure rate is around 90% plus. The same leukemias in older patients, it's pretty abysmal. I mean, it's pretty low. So it almost seems like as cells mature and grow older, it just seems like we lack that immune system to correct that problems. I was going to say one more thing and I forgot. But I think at least some things to keep in mind. But, oh yeah, I think this is the one. So one in Wang 2023 JAMA article, there was like a GLP-1 agonist. They had shown that there were some early signs of them actually reducing the risk of cancer. And again, I still feel that's just part of the story here, because again, coming back to the hyperinsulinemia, being obese, that drives some of the part of the cancer, but some of the newer drugs, which really were supposed to be treating for diabetes, they also seem to be reducing the risk of cancer too, which is still early to say, but I find it very interesting that that's happening.
So we get towards the end here, but what about CRISPR and genetic engineering as far as treatment of cancer?
I think it's an interesting area. So CRISPR, for those of you who don't know, is a way of editing genes, and it's a precise molecular scissor. So you can actually go in there and take out a bad gene and put in a good gene. So most of the work in therapeutic CRISPR or gene editing, as it's known, has been a little disappointing to date. So this is in non-cancer, and so a good example is Duchenne's muscular dystrophy. It's caused by one gene, and there have been drugs developed for this disease and given to a small number of people. It's incredibly expensive. If you think those drugs, it's about, one of those treatments could be $2 million to treat a patient. But the results have been very mixed, and there have been some deaths with it. So it's still in its infancy. I think it has a tremendous amount of promise. It could potentially, so we have this concept now in cancer called interception. What does that mean? Most cancers start from benign cells going to a premalignant cell. I talked about the adenomas in colon cancer, where it's very well described. Breast cancer, too, there are premalignant lesions, or ductal cancer in situ, which is not invasive and doesn't behave like cancer. So what we're moving towards is this concept: can we find these premalignant lesions and do something about them? And most of that work's not yet in doing gene editing in people, but there are other ways to use some of the drugs we've been talking about tonight to change that. But it could be. It's been a little disappointing. It's gone a little slower, and it's been a rockier road than I think we thought a few years ago.
Okay, so I want you to get your crystal balls out and think about where oncology, cancer therapy will be in 20 years. We have supercomputers, we have AI, we have nanotechnology, we have messenger RNA vaccines that are emerging for treatment of cancer. So are we going to, in 20 years, are we going to reach the Holy Grail and cancer will be something behind us?
No.
Wow. You're asking some very weighty questions tonight. It's great. I think cancer will still be here in 20 years. I think the way we treat it will be materially different. I used to say that to my trainees, like, you still have to learn chemotherapy, because especially when immunotherapy came out, and we thought that was 10 years ago now, and you're going to still be using chemotherapy through your career. I don't think that anymore. I think traditional cytotoxic, and I just came to this decision in the last year or so, because the technology has improved and no one is developing what are called classical chemotherapy drugs anymore. So the drugs, they moved on to something called antibody drug conjugates, which are some of the ones we mentioned, which is a new way of delivering chemotherapy, if you will, in a much more targeted fashion. And that's just the beginning. And the immune system, the immune system is fantastically complex, and we know just a little bit about it, and yet still we have great drugs. So I think the therapies will evolve over 20 years. I think we will not cure all cancers in 20 years, but we will be much further down the path of doing that. And for people who come in with advanced cancers, I do think we'll be able to really call them chronic diseases, like we call diabetes a chronic disease today, where people could live with it for decades. That I do think will happen in 20 years.
So one of the examples I remember was in my residency, like the pediatric professor used to tell me, like, some of the vaccines which are being given right now, like for the Haemophilus, the pneumonia, they used to have hearing. I mean, I didn't know this, but they used to have like hearing loss in babies because of they didn't get those vaccines because of the natural evolution of the history of the disease. But we don't see that anymore, just because there are so many good vaccines which have actually prevented that from happening. And maybe it's just wishful thinking, but I don't think we'll probably see stage 4 disease in a lot of cancers. I think we may still see quite a few, but not as much as we see right now. And I don't think we'll probably seeing natural history or progressions of different cancers metastasizing to different locations that much. Also, I strongly believe the exponential nature, the hockey stick nature of the AI. I don't think our human mind can comprehend as to how things will be. If somebody can tell you exactly how it's going to be in 20 years, I don't think that's we can ever believe that.
If the robots don't kill us.
Well, thank you very much. Panel was, I learned a lot, enlightening. Thank you for your introspective answers. Really appreciate it. So thank you very much.
Thank you. Thank you for your moderation.